I am going to start sharing my screen, and Assemblywoman Thomas is at a conference, a national conference. She thought she'd be able to get away, but she is not able to. She has asked Ms. Lee to serve as acting chair. So.
Good afternoon, everyone. I'd like to call this meeting of the SURG Treatment and Recovery Subcommittee to order. It is December 6th at 2:06 p.m. Thank you, everyone, for joining us. And Kelly, can you go ahead and call roll, please?
I shall. Thank you. Kelly Marshall for the record. Assemblywoman Thomas. Chelsea Cheatham.
Present.
Dr. Dixon.
Here.
Jeffrey Iverson. Acting Chair Lee.
Present.
Steve Shell.
Here.
Madam Acting Chair, we have a quorum.
Wonderful. So our next item on the agenda is public comment. And just a reminder that public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If there's anyone in the audience who would like to comment during this first public comment period, please unmute yourself and state your name for the record.
I do not see any hands raised, Madam Chair. This is Kelly Marshall for the record.
Okay, great. So hearing no public comment, we'll move on to agenda item number 3, which is to review and approve the minutes from our October 25th, 2022 Treatment and Recovery Subcommittee meeting. And so we'll open it up for any motions to approve or any discussion regarding the minutes.
Madam Chair, this is Steve Shell. I will make a motion to approve the minutes from our October 2022 meeting.
Thank you, Steve. We have a motion.
I'll second it, Dr. Dixon.
And Dr. Dixon, thank you for the second. All in favor of approving these minutes from our October 25th meeting, please signify by stating aye.
Aye.
Aye. Any opposed? Any abstentions? All right, motion carries unanimously. And now to the meat of today's meeting, agenda item number 4, which is to finalize subcommittee recommendations. And so take us away, Kelly.
Okay, thank you. Kelly Marshall for the record. So just as you approved your October minutes, meeting minutes, you would note that you approved the first 3 recommendations with justifications, action steps, and references. And so the objective for today is to complete recommendation number 4, and then you have not yet reviewed 5 or its action item, justification and research links, or 6. So it's basically completing the rest of 4. You did make a motion and you approved 4, which is listed on the screen. And that's to implement changes referencing the October 3rd meeting attachment with the highlighted Commission on Behavioral Health draft letter to the governor from June 23rd to recruitment, retention, and compensation of health and behavioral health care workers. That was a change that you made. Enhance compensation in alignment with the Commission on Behavioral Health Board's letter to the governor of June 22nd. Additionally, continue to sustain and expand investment in community health workers, peer recovery specialists, and certified prevention specialists by implementing changes to recruitment, retention, and compensation. So this has been approved by you at your October 25th meeting. And what we need, we actually did describe the justification, so that's why you don't see for subcommittee to develop. Where we left off was the action step. And so the question is, these action step items were submitted by you as members individually via survey. So it was independent communication. It was not a circular communication. You sent them directly to SEI. SEI put them in as received into this document. And that is what your first act would be, is to review the action steps and then to see if you wanted to make any changes to the research links. I believe the process that we used previously is that we would approve this and then we would move to the next recommendation, which would be recommendation 5, after you make any changes and then make a motion.
Lisa Lee, for the record, I have a question regarding those policy change in legislation, items 1 and 2. To me, those sound like the same thing. Am I missing something, that those are two different? I'm assuming these are two different submissions from members, but I'm wondering if there's an opportunity to condense them so it's just one, because they are mirroring each other, if anyone has any ideas.
Yeah, so I think Kelly Marshall, for the record, 1 is changing it, right, to allow for reimbursement of community health workers. The other one is to evaluate and increase Medicaid reimbursements. And it's broader than community health workers. It's also CPSs and PRSSs. So slight nuance between the two.
Lisa Lee, for the record, this is a question for Chelsea, who may know more about certified prevention specialists. Are CPSs reimbursable under the current Medicaid structure?
I don't believe so, no.
Okay.
Hello? This is Leslie. Right, hold on 1 second. I gotta mute my.
Do we have any thoughts around proposed language on this?
This is Chelsea Cheatham, for the record. I don't really have any changes. I think it looks fine as is.
Lisa Lee, for the record. Chelsea, would you be amenable to the first one, the change in Medicaid reimbursement to allow for reimbursement of CHWs to also include CPSs?
Yes, Chelsea Cheatham, for the record. Yes, I like that change.
Lisa Lee, for the record. So if the first one allows for the change to include CHWs and CPSs, I would recommend changing the second recommendation to just get rid of that parenthetical citation of the CHWs, CPSs, and PRSSs. Just remove that entirely so it broadly covers behavioral health certified or licensed professionals and paraprofessionals.
Madam Chair. So Kelly Marshall for the record. So if I'm to summarize under what is recommendation 4A, bullet point 1 would change to say, change in Medicaid reimbursement to allow for reimbursement of CHWs and CPSs affiliated with BH/SUD. And the second bullet would say, Medicaid reimbursements for behavioral health, including paraprofessionals, must be evaluated and increased to recruit and retain qualified behavioral health professionals.
Yes, Kelly, I think you captured it perfectly. I see Steve shaking his head.
Oh, no, Madam Chair, this is Steve Shell. No, I agree with these changes. Absolutely.
Perfect. Well, do we have any further discussion on those, the first portion, the policy change in legislation A, bullet point 1 and 2? Should we go on to B, funding? So funding, the first one says expenditure of settlement funds through grant dollars and direct DHCFP, what is that, Department of Healthcare Financing and Policy, to create grant opportunities for organizations to employ CHWs affiliated with behavioral health and substance use disorder and be reimbursed for services provided to non-Medicaid individuals. Grant opportunities. What do you all think of, again, broadening that language? Or
Madam Chair, this is Steve Shell. I would recommend adding the CPSs to that second bullet like we did under 4A.
Perfect. And should we, do we want to include PRSSs as well?
This is Chelsea Cheatham for the record. Yes, I would like to include PRSSs there as well.
Lisa Lee for the record, one additional question for this group. What about non-Medicaid individuals or underinsured folks having access to behavioral health clinicians? Do we want to also extend additional funding to be allocated for uninsured or underinsured folks or people within that gap to be able to access? Or just remain with the paraprofessionals?
So, Madam Chair, this is Steve Shell. When I initially was looking at this, my thought when regarding non-Medicaid would include the uninsured. There may be a better way to state it, but that was my initial thought.
And Steve, Lisa Lee for the record, Steve, do we want to be more inclusive of just behavioral health and SUD services? Or do we feel that the CCBHCs and FQHCs have a handle on that and we're looking to offer more paraprofessional services? I just want to make sure that the action steps align with the broader vision of this goal.
So Steve Shell for the record, I think, yes, I think that the CCBHCs don't have the bandwidth to do everything. I think as everyone originally thought. So I think the more we open that up and make it very broad, the better.
Lisa Lee for the record. So I'm wondering if there's an opportunity, given the broader recommendation, which I'll go back to that just so we can kind of coordinate our efforts so that they're in alignment. It says implement changes to recruitment, retention, and compensation of health and behavioral health care workers and enhance compensation in alignment with the Commission on Behavioral Health Board's letter to the governor of June 22nd, yes, sorry. Additionally, continue to sustain and expand investment in community health workers, peer recovery support specialists, and certified prevention specialists by implementing changes to recruitment, retention, and compensation. So just for clarification, the way I read that is behavioral health care workers broadly. And it says health and behavioral health care workers broadly, and then sort of, and also these paraprofessionals. Is that how you all understand this recommendation? So I'm wondering if there's an opportunity for the action steps for policy change in legislation to also open up that language a little bit? Or do we want to be laser focused on some of these unfunded opportunities, currently unfunded opportunities? Kelly, if you could take us back to the action step B. Yeah. Thank you.
So Madam Chair, Chelsea Cheatham for the record. Are you suggesting that we also include the behavioral health specialists in that second bullet point?
Thank you, Chelsea. Lisa Lee for the record. I do think that the language could be expanded personally. I'll default to the group's answers for this, but I feel that since our policy change recommendations are to kind of fund these the CHWs and CPSs that are currently not funded under the Medicaid structure, and also the second piece of behavioral health and paraprofessionals broadly, that there's an opportunity to also request from the department or division. I always get that so confused. Division, I think,
It's
of
a
healthcare, division of healthcare financing and policy, to create grant opportunities for organizations to employ. And do we just want it CHWs, I guess, is the question? Or do we want an expanded array of services beyond, current CCBHCs and FQHCs for other organizations to also provide for this pocket of individuals that are not currently able to access services because they're either uninsured or underinsured?
I like the idea of expanding this as much as possible. So I fully support adding in other behavioral health professionals to that second bullet point.
Thank you, Chelsea. Lisa Lee, for the record, I'm also wondering if there's an opportunity to tweak that language there from non-Medicaid individuals to uninsured and underinsured, or even, I've seen people with private health plans that they just get caught in this hole where they're really not able to access specifically opioid use disorder treatment. And it's mind-boggling because then I have people telling me like, should I quit my job and go on Medicaid? And I'm like, no, you should not quit your job and go on Medicaid. But they fall into this hole, right? This gap. And so I personally feel that this litigation funding should cover these gaps that we're seeing with and expand access to people who aren't able to access them. I think our Medicaid population is really, really covered, but that's a smaller percentage of our total population who's in need of services. And I'm going on a rant, but I wonder if there's another way to word that so that your average layperson could understand, like, oh, that's me, right?
Yeah, Madam Chair, this is Steve Shell. Yes, I would recommend to change non-Medicaid to underinsured and uninsured individuals. I totally agree that we have this pocket of our population that even though they may be insured, a lot of them can't afford the copays and the deductibles. And so they're forfeiting, they're just ignoring their mental health needs and other healthcare needs. So any kind of assistance in that area, I think, will be very helpful. We also, excuse me, Madam Chair, Steve Shell again. We also have a lot of organizations that have been adjusting their sliding fee scales. And so I think maybe this would even help encourage more organizations to focus on those sliding fee scales.
Thank you, Steve. Those are great points. Those are great points. And you're right. People do delay care or just, wait until it's an emergent need and then get their care that way because they've been putting it off. You're absolutely right. Any other ideas around that? Poor Kelly, have you been taking notes?
Madam Chair, Kelly Marshall for the record. So I was actually chatting Laura Hale. And so I missed the first part of the change with to employ CHWs, but I believe Laura Hale has captured it. And then I do have the second change, which is to change provided to non-Medicaid individuals to provided to underinsured and uninsured individuals. So Laura, do you have the first part of that change on 4B bullet point 2?
I do have it. And just on your question, Division of Healthcare Finance and Policy is a creature under Medicaid. That whole division is funded that way. They don't, they sometimes run demonstration projects under Medicaid, but in terms of grants to non-Medicaid populations, that would not be that division. That would, there is the grants management unit that's under the director's office. There are sometimes grants that come out under the Division of Public and Behavioral Health, but Medicaid, which is the same thing as the HCFP, would not typically do that. So it's a little bit, if you want somebody to direct grant opportunities to organizations, so there are lots of nonprofits and like the FQHCs and so forth that do help people who don't have Medicaid or are underinsured or uninsured, as you say, but those would come out someplace else. So it may be that you don't want to, you may just want to say direct DHHS broadly because they are over all those divisions and could maybe find a way to help, who you're looking for.
Lisa Lee for the record. Thank you, Laura. I totally agree. I didn't even think about that, but yeah, I would say DHHS.
Madam Chair, this is Steve Shell. I'm so glad that Ms. Hale brought that up. I hadn't even thought about that either, but she's absolutely right.
Mm-hmm.
And Madam Chair, for the record, Ms. Hale, prior to supporting SEI in this subcommittee, actually worked for both the director's office, so DHHS, and has worked for DHCFP.
Wonderful insight. Thank you, Laura, for bringing that to the table.
You're very welcome.
So Laura, I'm still missing the first part. So if it says direct DHHS to create grant opportunities for organizations to employ, this is what I'm missing. What was the change besides CHWs?
Sorry. So we had or others was what had been suggested, and other behavioral health providers generally. So that was what I had in my notes.
Okay, so Madam Chair, Kelly Marshall for the record. So direct DHHS to create grant opportunities for organizations to employ CHWs or other behavioral health providers. affiliated with behavioral health and substance use disorders and be reimbursed for services provided to underinsured and uninsured individuals.
Lisa Lee for the record. Group, do you think that that captured everything we chatted about?
Chelsea Cheatham for the record. Yes, I believe that captured everything.
Woohoo, we did it.
So then I think the other question, Madam Chair, Kelly Marshall for the record, would be if there are any changes to the research links or if we're comfortable leaving them as is, in which case you could make a motion or you could call for a motion.
Awesome. Lisa Lee for the record. Any discussion on those research links? Or anything to add? All right. Well, hearing none, I think we're looking for a motion.
Chelsea Cheatham for the record. I motion to approve recommendation 4 with the changes to the action steps A and action steps B that were presented by Kelly Marshall.
Thank you, Chelsea.
Madam Chair, this is Steve Shell. I will second.
And we have a second. All right, all in favor of adopting this recommendation in its full glory, please signify by stating aye.
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 Any in opposition? All right, unanimously, we approve of this. We'll move on to that next recommendation.
So Madam Chair, this is recommendation 5. Again, this has been presented multiple times to this subcommittee. It is to facilitate entry into treatment, ensure that BIPOC, standing for Black, Indigenous, and People of Color, communities are receiving overdose prevention, recognition, and reversal training and overdose prevention supplies, such as fentanyl test strips and naloxone, to reduce fatal overdoses among Black and Latinx Hispanic individuals in Nevada.
Lisa Lee for the record. Thank you, Kelly. And we are working on, what is the second piece of this? The justification?
Yes. So there were no, just point of clarification, Kelly Marshall for the record, from the October SURG meeting, there were no comments sent back to the subcommittee related to revising this recommendation. So you had previously approved the recommendation. If there are no concerns about the recommendation, then you could move to the justification and the action steps that we received via survey and the research links.
Okay, perfect. Thank you for that clarification, Kelly. So we'll open it up to any discussion around any revisions that you may think need to be done to that recommendation. Recommendation 5. Or are we good with the current language?
Sorry, I want to jump in late, but I'm here now. If there were any questions that were missed or that you needed me for, I apologize for the late entry. Let me know if there's anything that I was needed on or that you need now.
Thank you. Is that Jeff?
No,
Oh.
sorry, Kelly Marshall for the record, that is our DAG.
Or Dad?
That's DAG.
Oh,
Becker.
Yes, apologies. Joel Becker for the record.
hi, Joel. Welcome. Thank you.
Chelsea Cheatham for the record. So one of the suggestions that I have is, could we kind of I just want to change the wording around a little bit. So maybe change it to, in order to ensure that BIPOC communities are receiving overdose prevention, recognition, and reversal training, and overdose prevention supplies, and maybe moving the facilitate entry into treatment there. Just so that it just kind of reads a little bit better. Because I think the focus is not really to facilitate entry into treatment, it's really to ensure that BIPOC communities are receiving the overdose prevention and also those harm reduction supplies.
Madam Chair, Kelly Marshall, just with context. So originally, the recommendation that you had approved began with ensure that BIPOC communities are receiving overdose prevention. The feedback that you received was that it did not seem to sit in the treatment and recovery recommendation. And the last time you revised this recommendation, you revised it to add to facilitate entry into treatment. So just providing context about how to facilitate entry into treatment ended up at the very beginning of that sentence and why.
Thank you, Kelly. They say the key to happiness is a short memory. I'm a very happy person. I totally forgot that piece. Lisa Lee for the record. I also agree with Chelsea, though, that that maybe we could move that. I think you brought really great points to the table, Chelsea. So I'm wondering if there's an opportunity to modify that to what Ms. Cheatham suggested, which is to ensure that BIPOC communities are receiving overdose prevention, recognition, and reversal training. And then, comma, overdose prevention supplies such as fentanyl test strips, comma, naloxone, comma, and facilitation into entry into treatment or something like that. Does that make sense? That sounds like a really, really bulky, meaty sentence, but and to facilitate entry into treatment.
Oh, this is Dr. Dixon. Actually, I was the one that added that little statement at the beginning to make sure that it stayed part of treatment, because otherwise without that, it looks like it belongs in the prevention subcommittee. And if you put it somewhere else, it's going to get lost. And these long run-on sentences are problematic as they are. And which I think probably this should be broken up into 2 sentences somehow. But anyway.
Thank you, Dr. Dixon. It's also the treatment and recovery subcommittee. So I'm wondering if there's an opportunity to say to facilitate opportunities for recovery. Because really we have to keep people alive, and so I guess I'm pitching to the group, what would you think of that as the starter, particularly Chelsea, like to facilitate an opportunity for recovery?
Chelsea Cheatham for the record. I like the idea of changing it to facilitate entry into recovery, or to facilitate the opportunity to recover.
And I guess this question is for Dr. Dixon. Lisa Lee for the record, would you be amenable to that change, since this is the treatment and recovery subcommittee?
Well, yeah, I don't care if you had recovery, that's fine with me. I'm not sure I'd take out treatment though. The big problem is that we are not, it's quite clear from what I do, we are not reaching a lot of these communities. They're not coming into treatment. And why, I'm not sure. I think it's education and maybe some stigma issues and all kinds of issues going on. But if we don't get them into treatment, then they don't get into recovery for the most part. It's hard to go into recovery without doing treatment.
Lisa Lee for the record. I do just want to say on record that there are a ton of there's a ton of evidence in the science that a lot of people enter recovery without ever going to treatment. I mean, going way back to a book called Coming Clean, which really facilitated a lot of theory in this field. But I do just want to say that I think Coming Clean was by Zimmerman, who did a lot of work on empowerment theory in particular. But there are a whole bunch of folks who do get into recovery without treatment and spontaneous remission and things like that. So I don't necessarily think that treatment is always the way that someone enters into recovery, that there are multiple pathways into recovery. So I did just want to say that on record.
Chelsea Cheatham for the record. I think just another small change to this one is that at the last line just mentions Black and Latinx Hispanic individuals. But if we're using the word BIPOC or the acronym BIPOC, we probably should also add Indigenous and people of color in there as well.
Well, I agree that we're somehow missing that this BIPOC is not well understood probably by a lot of people. So I would say that both at the beginning and the end, we ought to have these groups listed. Because right now it looks like I'm not even sure they're the same thing, you know, so it's like, or at least we're leaving somebody out at the end.
What do you think, Kelly?
So, Madam Chair, Kelly Marshall for the record. So I heard several different things that I'm not sure have been resolved. And Laura, please correct me if I'm wrong. First, I heard to facilitate opportunities for recovery. Then I heard to facilitate the opportunity to recover. And then I also heard Dr. Dixon say that she would like to include treatment. So that could be something like to facilitate opportunities for treatment and recovery. Ensure that Black, Latinx, Hispanic, Indigenous, and people of color are receiving overdose prevention, recognition, and reversal training and overdose prevention supplies such as fentanyl test strips and naloxone to reduce fatal overdoses. And you could say among, list them all again, or these populations in Nevada.
Thank you, Kelly. Lisa Lee for the record. I want to, sorry, the book I referenced, Coming Clean, Overcoming Addiction Without Treatment, is by Robert Granfield and William Cloud, who did a bunch of work on Recovery Capital. They were kind of like the runners of that before William White got involved. So I wanted to just clarify that. And also I wonder what you read, Kelly, about treatment and recovery, if we can put and or recovery, just because I think Chelsea is probably coming from the same pure spirit that I'm coming from, in that we meet people where they're at. And not everyone's goal is treatment. Not everyone's goal is abstinence-based recovery, but we can hope for recovery as in improving their health and wellness, as recovery is defined by SAMHSA. and honoring self-direction and autonomy and all of those things, but we have to keep people alive. And so I think this was written in the spirit of that. Correct me if I'm wrong, not necessarily, sorry about that, not necessarily with the intention that, everybody is going to recover in the same way.
Madam Chair, Kelly Marshall for the record. So if I recorded what you stated correctly, we went back to the language of to facilitate entry into treatment and or recovery, as opposed to the other options, opportunities for recovery, the opportunity to recover. So we just want to make sure that we have your language accurately reflected. But if I were to take what you stated, it would be to facilitate entry into treatment and or recovery, ensure that Black, Latinx, Hispanic, Indigenous, and people of color are receiving overdose prevention, recognition, and reversal training and overdose prevention supplies, such as fentanyl test strips and naloxone, to reduce fatal overdoses among Black, Latinx, Hispanic, Indigenous, and people of color individuals, or, as I said, the populations described previously in Nevada. So there's a nuanced change when we shifted from BIPOC communities, and I don't know if there is an implication for talking about like prevention and training. Are we focused on the individual, or are we focused on the communities at large that are encompassed by BIPOC populations?
Thank you, Kelly. And Lisa Lee, for the record, I think I screwed that up. I screwed up your beautifully worded thing where you said facilitate opportunities. And I really do like that. I don't know what the group thinks. I really liked that language, how you said it. The only change that I would request would be and or. And then I'll give it to the group around the question around communities or individuals.
I think the challenges that Kelly Marshall, for the record, the challenges are that people of color followed by communities is like just an awkward descriptor. So you are talking about communities. You're talking about Black, Latinx, and Hispanic, Indigenous, and people of color. And then we shifted to individuals at the end of the sentence. So it's communities in the beginning of the sentence and individuals at the end of the sentence, because we included those descriptors in both. So I think if you can just come to consensus about, is it communities? Is it individuals? Is it both?
Lisa Lee, for the record. So I believe that I pitched this one to begin with. And so I think my intention behind that was the way I see it. There's a lot of communities in which there are folks in those communities that are leaders within communities, right? So thinking about tribal communities across Nevada, thinking about all of the places, churches, temples, all kinds of things. There's leadership there. There's capacity for change that is not really being included in these conversations. And so I would call that communities that are being missed. And not just that, but in culturally and linguistically appropriate ways of providing education. And then I would also say that the goal is to reduce death and harm in individuals, right? Of course, broadly that affects communities, but I guess my intention was to build leadership capacity and empowerment within communities that would spill out into decreasing harms within individuals, if that makes sense. So that was my my motivation for using those two terms, because you are looking at communities and then you are looking at individuals. I hope that makes sense.
So Kelly Marshall, for the record, so if I can read back what I think you just restated, was to facilitate opportunities into treatment and or recovery, ensure that Black, Latinx and Hispanic, Indigenous and people of color communities are receiving overdose prevention recognition and reversal training and overdose prevention supplies such as fentanyl test strips and naloxone to reduce fatal overdoses among Black, Latinx, Hispanic, Indigenous, and people of color individuals, or you could just say people of color in Nevada. People of color in Nevada.
What do we all think of that?
Chelsea Cheatham, for the record, I think it sounds great. Just the way you read it just now, Kelly, I think that sounds perfect.
So Kelly Marshall, for the record, Madam Chair, do you want to move then to the justification, the action steps and the research, and then you could take a motion to adopt?
I think so. Is everybody feeling ready to move on to the justification piece? Okay. Steve, you're now completely shrouded by light.
I've disappeared. No, I'm really here.
Kelly Marshall, for the record, Steve Shell has self-actualized.
Thank you, Kelly.
Okay, so Madam Chair, Kelly Marshall, for the record, the justification includes citations, but does not include the justifications that align with the way you provided justifications previously. So I don't know if you want the citations to be moved down to the research links and for you to, as a group, describe your justifications in a digestible, understandable way for your audience.
Thank you, Kelly. Lisa Lee, for the record. Is everyone familiar with those research links there? It's Sean Thomas's work. One is the Sudor report, and the other one is oh gosh, notes from the field. He also published an article with Dinwiddie and Monroy that was published earlier this year regarding the increase in Hispanic deaths across Nevada.
Chelsea Cheatham, for the record, I'm comfortable with the way that the justifications are right now, but do we want to maybe put a small summary? That way it kind of matches what we've had for justifications in the other 4 recommendations.
Lisa Lee, for the record, Chelsea, I think that would be beneficial. So looking back at previous justifications, it looks like just a few quick notes, maybe 1 or 2 points about why this is needed.
Yeah.
So I think we can start with surveillance data in Nevada indicate disparities in overdose and drug poisoning fatalities across Nevada, or racial disparities. Would you say that that sums up one of the justification pieces?
Chelsea Cheatham for the record, yes. I think that sums up probably number one. And I think number two, when you were speaking just now, Madam Chair, you kind of summarized what that one is. So I think maybe we could use exactly what you said as like, because it was a really quick summary.
Thank you, Chelsea. I'm wondering, Dr. Dixon, you mentioned some observations from where you sit in the treatment world regarding racial disparities. I'm wondering if there's an opportunity to speak to that as well.
Well, it would be an observation. I don't know that anyone is really collecting any data out of our clinics of this sort. So I don't know, but
Thank you, Dr. Dixon.
I mean, like I say, maybe something like it's been noted that I don't know how to say this. It's been noted that because we see very few people of color in the clinic, we're assuming that they are not being reached as much as necessary. But I don't know how to put that any better than that. But I mean, I do have Black patients, but I definitely don't have much in the way of Latino or indigenous people at all. It's yeah, very few. So I don't know.
Thank you, Dr. Dixon. Although, Lisa Lee, for the record, although the state didn't end up giving me TED's data, which I think would be really helpful for this conversation, I do have some data. I'm just looking at it right now to see if there's anything useful regarding race and ethnicity. I do have hospital emergency department encounters, as well as inpatient admission data that break down race. Let me see what I can do here. It's also broken down by county, so I'm not sure if I can. Give me a second. Thank you, everyone. Lisa Lee for the record. So just looking at the crude rates broken down by race across time, it is apparent that Black and Hispanic, and let me look at Native. Yeah, Black, Hispanic, and Native American crude rates of inpatient admissions have gone up, have increased. You look at same with emergency department admissions. This is just looking at opioid related data though.
Madam Chair, Kelly Marshall for the record. So in the spirit of the recommendation, which is focused on overdose prevention, recognition, and reversal, seems like overdose data would be appropriate as a proxy.
Yeah, I'd agree with that. I mean, that's the, I guess in a way, the best data we have is the overdose.
And you
Emergency
said
room
opiate-
overdose and reports of deaths. That's what we have to assume that translates into how much, who's using what, and why are they not in treatment or in recovery? What's the problem there?
Yes, Lisa Lee for the record. So Kelly, I think there's an opportunity to include so fatality data for overdose and fatal drug poison or drug poisoning fatality data and opioid related hospital billing data support. There's a growing racial disparity that is not fully being addressed across Nevada. Does anyone on this call also have any data with regard to race and ethnicity and an overdose aside from these death and hospital data?
Madam Chair, just a point of clarification, Kelly Marshall for the record. I believe when you stated the justification number 2, that data that you indicated it was also Hispanic, which would be race and ethnicity.
Correct, race and ethnicity. Mhm.
Chelsea Cheatham for the record. No, I don't have any statewide data available. I do have data specifically for people who are receiving services at Track the Exchange. That may be beneficial to put in here, but it may take me a few days to be able to get that information, but maybe some data on overdoses that have been reversed that may have information that includes race and ethnicity.
Lisa Lee for the record. Chelsea, is there anything anecdotally that any information you can provide regarding what you may have seen on the front lines in Las Vegas with regard to who's getting their overdoses reversed, who's not?
Nothing that I can think of anecdotally. And I think this kind of goes back to recommendation, back to this recommendation specifically. The vast majority of clients that Track B was serving were white Caucasian. So, you know, I think there's definitely some outreach that can be done to the BIPOC population just to have people, you know, even come in to get harm reduction products. So no, I can't think of anything anecdotally that we could add here.
Thank you, Chelsea. What do we have, Kelly?
So Madam Chair, I have what I believe are 2 bullet points. The first justification is that surveillance data in Nevada indicates racial disparities in overdose and drug fatalities in Nevada. And the second is that fatality data and opiate related hospitalizations support that there is a growing racial disparity not being fully addressed in Nevada.
Thank you, Kelly. Two recommendations from me. One is indicate instead of indicates, because to just go with the plural of data. And then the other one was race and ethnicity for the second bullet point, or the second justification. I think we wanted to weave that into there.
So growing racial ethnic disparity, not being fully addressed in Nevada.
Yeah.
Okay.
I think so. What do you all think? Does that sound, is that better than our links? Anything else to add? All right, well, I think we're ready to move on to our action steps. Kelly, as a point of clarification, do we also need a policy recommendation, or is just a funding recommendation okay?
So you can, the options, Kelly Marshall for the record, the options that were provided in the survey and that have been used kind of generally were not and, they were or, and it was funding, policy, or other, right? So legislative, for example, was an other. So you just received funding recommendations.
So what does OEND stand for?
Lisa Lee for the record, overdose education and naloxone distribution.
Okay.
Well, gang, what do we think?
Chelsea Cheatham for the record. I think the funding recommendations look good exactly the way they are. And I'm trying to think if there is a policy recommendations. Maybe need another minute or so to think if there's a policy recommendation that I want to make.
Thank you, Chelsea. Lisa Lee for the record, Kelly, my only recommendation would be to put overdose education and naloxone distribution with OEND in parentheses.
Kelly Marshall for the record, Madam Chair, we would go through and spell out, and the report actually uses that approach with the acronym then after. I also wanted to note that Laura messaged me and reminded me that there was a lot of data related to racial disparities presented by Mercer in the needs assessment.
Perfect. Thank you, Kelly and Laura. Do we have any other comments on funding while we're thinking about policy? Well, hearing none, let's loop back around to the policy piece. Chelsea, do you have any policy recommendations?
No, so one of the things that I'm thinking of is, and I'm not sure if this can be done, is to, if DPBH is having some grant applications or grant opportunities or creating any, or even DHHS, that there is a requirement for there to be funding for specifically doing like OE&D trainings with BIPOC communities, or if it's harm reduction related, that there's something specific for BIPOC communities. If it's treatment related, that there's something specific for BIPOC communities written into all grant opportunities.
Lisa Lee for the record. So I think that's a request for Kelly and or Laura. I know that there was another category, but I can't remember what it was. Policy, funding, or other. And then where would regulate, because that sounds like a regulatory, well, not necessarily regulations, is because it wouldn't be in the regs and it wouldn't be like within statute, but it would be a DPBH requirement. Is there an opportunity, because that goes into the funding thing again, is there an opportunity to add another bullet point that says direct DPBH to require a portion of funding be allocated to projects that are specifically conducting outreach, so we can broaden the language a little bit, outreach to BIPOC communities or something like that. You could probably spiff it up a little bit, Chelsea.
No, Lisa, I think that sounded great. I think that would be exactly what I would like to add. Just not sure exactly where it would go.
Lisa Lee for the record, thinking about SAPTA, because most of those grants come from the SAPTA grant funding. And thinking about SAPTA policy versus sort of NRS and NAC and all of that. I'm just wondering, I'm not involved in the SAPTA world as much as probably some other members on this committee. If there's an opportunity that could be a policy recommendation to direct SAPTA to consider policies requiring organizations or at least, I don't know about requiring organizations, but
Madam Chair, I see that Laura Hale has wanted to provide some context.
oh, perfect.
would,
Thank you, Laura.
Federal funds that come through the department, no matter what division it is, they always have requirements in there about serving those broad populations. You also have specific elements of the legislation that created the SURG saying you must do outreach to special populations. And so, and it defines them within that legislation. And so I wonder, you know, instead of struggling with each recommendation that you're doing here, if you just referred back to and the special populations identified under AB 374.
And SB 390 section 7.5, I believe.
There you go. There you go. So you don't have to recreate all that every time.
Chelsea Cheatham for the record. So would we just want to add maybe another third bullet point under funding and then just refer back to those two things, the one that you just listed, Lisa, and the one you listed, Laura, and just leave it under funding as opposed to policy?
I'm good with that, Chelsea. Other members, any thoughts around funding or policy? Kelly, do you have any final verbiage for us?
Ish, Kelly Marshall for the record. So if I understand, it's a policy recommendation, and this is where I'm not sure how broad we go, or you went. Ensure that all recommendations, is it all recommendations or this recommendation? Ensure that all recommendations address special populations as defined in AB 374 and SB 390. And then the action step is actually applying to all of the recommendations in the report. That's what I'm.
So
Sorry.
Chelsea Cheatham for the record, I think we could probably make it specific to this one and state that funding from this recommendation would include all special populations listed. And then just kind of add exactly what you said at the end there, Kelly. But I think maybe my suggestion is to kind of keep it specific to this recommendation and keep it specific to funding.
So Madam Chair, that would be ensure that funding related to this recommendation address all special populations as defined in AB 374 and SB 390.
That works for me. And I was just going to pull up the language for what that is. I'm not sure about the AB 374. I'm so sorry. I've been working on this AB 390 document. Give me 1 second. I'm sure the language mirrors one another. But SB 390 section 7.5 defines special population as a population uniquely affected by substance use or substance use disorder, including veterans, persons who are pregnant, parents of dependent children, youth, persons who are lesbian, gay, bisexual, transgender in questioning, and persons and families involved in the criminal justice system, juvenile justice system, and child welfare system. It does not, however, specifically define BIPOC communities in that special populations in SB 390. If anybody has SB or AB 374 handy, I can look that
Laura
one up too.
does. Madam
Laura
Chair,
does.
Kelly Marshall for the record, Laura
Perfect.
Halehouse, because that is what will go into the report. Correct, Laura? Or no?
I'm sorry, you're saying,
No, just go ahead and share what's in.
okay, so special populations includes without limitation, veterans, elderly persons and youth, persons who are incarcerated, persons who have committed nonviolent crimes primarily driven by a substance use disorder, and other persons involved in the criminal justice or juvenile justice systems, pregnant women and the parents of dependent children, lesbian, gay, bisexual, transgender and questioning persons, intravenous drug users, children who are involved with the child welfare system, and other populations disproportionately impacted by substance use disorders.
Thank you, Laura. Lisa Leaf for the record. What do you think, Chelsea? I think I liked the original language, specifically looking at targeting, because that's not called out in either of those bills.
Correct. Yes.
So
Chelsea Cheatham for the record. Yeah, I also agree. I like the original language.
So just Kelly Marshall for the record, point of clarification, which original language?
good
Is-
point, Kelly.
Are you referring back to directing DHHS or DPBH to require funding? Because I think you had resolved that that is a requirement already.
To
Or
allocate funding specifically for programs seeking to ameliorate the harms of substance use and conduct outreach in BIPOC communities. something to that effect that specifically calls out the spirit of this recommendation that isn't specifically called out in SB 390 or AB 374.
So, Madam Chair, Kelly Marshall for the record. Laura, I don't have it. So do you have it? But can you describe what you just wrote?
Oh, I was just writing that they wanted original language, as the BIPOC was not specifically called out in the legislation, but how that goes back to the original language, that question, too many iterations.
I did have Kelly Marshall for the record. I did have a note. Ensure that funding related to this recommendation addresses special populations. If that was the original language, no, okay.
Chelsea, was it akin to what I just said?
Yes, what my original thought was really akin to what you said just now, Lisa.
Do you want me to take a stab at it again, Kelly?
Please.
Direct.
Okay, hold on a second. So our other team member, Kelly Marshall for the record. Projects that are specifically conducting outreach to BIPOC communities was the part of the language. And then I heard you say ameliorate, to help ameliorate
The harms of substance use and conduct outreach.
So
Okay.
is it the funding piece though? Fund projects that are specifically conducting outreach to BIPOC
To
communities?
allocate funding to projects that specifically, just to make sure that there are opportunities for organizations that are specifically looking to reduce harms in their communities, that they're able to apply for funding. You know how SAFTA grants, well, several of the SOR grants had different sort of pockets for allocations, right? So there's like recovery housing, peer recovery support specialist services, harm reduction, like there were sort of different allocations. And so I would envision this, if I'm thinking correctly, Chelsea, you're a SOR veteran as well. Is that what you were thinking, is kind of like this funding priority area, and then also like outreach to BIPOC communities is one of those funding priority areas in the application?
Exactly, yes.
Okay, perfect. So then I do agree that it needs to be worded like direct PBH to specifically allocate grant funding.
Okay, so Kelly Marshall for the record. Direct DPBH to specifically allocate funding to projects that are specifically, so we have specifically twice, conducting outreach to BIPOC communities to ameliorate the harms of substance use disorder.
Yes, and we got to get rid of one of those specifically.
So I would say the first one. Direct DPBH to allocate funding to projects that are specifically conducting outreach to BIPOC communities to ameliorate the harms of substance use disorder.
What do you think?
Chelsea Cheatham for the record, I think that sounds great. I think that sounds perfect and what I wanted. Thank you.
So I think Kelly Marshall for the record, I think you would leave that under funding as well. Correct. And then am I also correct that we would take the notes out and just provide the links as part of the research links with the justification that you had?
Lisa Lee for the record. I would assume so, Kelly, yes.
Okay.
How are we feeling about this?
Madam Chair, this is Steve Shaw. I know I haven't said much, but I definitely agree with everything that's been said already. I don't have anything new to add.
Wonderful. Are we ready for anyone to put a motion out there?
Chelsea Cheatham for the record, I motion to approve recommendation 5 with the suggested changes to the justification and the action steps.
This is Steve Shell. I'll second.
We have a motion and a second. Any discussion on this? And just a point of clarification, Kelly and the DAG, would that also include recommendations to change the actual recommendation language? Does that need to be included also? Do we already take care of that?
I think it needs to be included. Kelly,
I'm sorry.
I think it needs to be included. I don't think you took action on the recommendations separately.
This is Deputy Attorney General Becca for the record. Do you guys need some clarification on a motion?
Yes, sir. Thank you.
All right, what's the issue?
So Chelsea, your motion was to adopt the justification, action step, and research links. Is that correct? Did you want to add? I think we also need to approve the recommendation changes as well.
Okay.
So Kelly Marshall for the record. So Dag Becker, we have a motion and we have a second, and the motion has been deemed to be incomplete. So could you advise the subcommittee on how to rescind that motion or amend that motion?
Yeah, that's easily superseded just by making a new motion. You could just move to approve the recommendation with the justification, action, and research with the changes that have just been discussed and that have been approved by the group. Apologies for my sniffles.
Thank you for being here.
Thank
So,
you.
Chelsea Cheatham for the record, I motion to approve recommendation 5 with the changes to the justification, action steps, and research links as discussed.
Is there a second?
This is Steve Shell. I'll second.
All right, we have a motion and a second. Thank you, Chelsea. Just wanted to make sure we dot all of our i's and cross all of our t's. All in favor, please signify by stating aye.
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 Any in opposition? And any abstentions? Motion carries unanimously. We'll move on to recommendation 6. It's our last one.
Let me go back, sorry. Okay, so Madam Chair, if I may, Kelly Marshall for the record. So your originally approved and reapproved recommendation was to significantly increased capacity is needed for intensive care coordination to facilitate transitions and to divert youth at risk of higher level of care and or system involvement. Implement a specialized child welfare service delivery model that improves outcomes for children and families affected by parental substance use and child maltreatment. In the October 3rd SURG meeting, Vice Chair Tolles suggested the following language: significantly increased capacity, including access to treatment facilities and beds for intensive care coordination to facilitate care transitions. This language would clarify that it's increasing access, which would include various avenues to get there, whether through public-private partnerships or the programs that Dr. Woodard described. Both of those issues came up during the SURG meeting. So a suggested alternate recommendation was to significantly increase, taking off the D, capacity, including access to treatment facilities and beds for intensive care coordination to facilitate transitions and to divert youth at risk of higher level of care and or system involvement. Implement a specialized child welfare service delivery model. No changes to that part. So I think the question is, do you retain your original recommendation 6? Do you tinker with the suggested alternate recommendation or look at Vice Chair Toll's suggested language, which includes the word intensive care coordination? That's right. That's for intensive care. So that her recommendation is included in the suggested alternate recommendation.
Thank you, Kelly. Any discussion on this?
Kelsey Cheatham for the record. I am in favor of adopting the suggested alternate recommendation, the suggestion from Vice Chair Tolles.
Thank you, Chelsea. Lisa Lee, for the record, I also agree that Vice Chair Tolles, or former Vice Chair Tolles, I don't know where, yeah, former Vice Chair Tolles. I think that her recommendation for the added language really kind of captures the intention of treatment facilities and beds. Any other discussion on this one? I think we could entertain a motion to adopt these changes before moving on. Is that correct?
I would defer, Kelly Marshall for the record, I would defer to Dag Becker.
All right. What's the question now? I apologize.
Thank you, Dag. The question is, could we entertain a motion to adopt the recommended language change from former Vice Chair Tolles now, or should we do that at the end and include it in?
Has Director Tolles suggested changes already been reviewed, discussed, deliberated, and voted upon, or just not voted upon?
No, because I think the question is, can we have a motion now to approve these recommended changes, a motion, a second, and a vote before moving on to the other pieces of that recommendation, or should we do it at the end after we review the whole
That's
thing?
a good question. Let's take a look at your agenda. The agenda just listed all as one piece. So then I would keep it as one piece and not do separate pieces to keep it as per the agenda descriptions.
So Kelly Marshall for the record. So Dag Becker. So in each of these recommendations, they're either revising the recommendation or keeping the recommendation they previously approved. And then they're building out a justification and action step and research links that all linked back to that recommendation. So on the previous recommendations, they have adopted it in toto, as opposed to breaking it into two motions. And I think the question is that okay for them to break it into two components, or should they? So it's this plus this, or can it be this and then this? That's the question.
I would stick to the agenda, and if it's listed as one item, vote on it as one item. If it's listed as a subsection of an item and then the item itself, that would be more justification for breaking it up.
So Kelly Marshall for the record. So Madam Chair, I think given how you have been adopting the recommendations, I would suggest that it sounds like my understanding of what Dag Becker is saying is that we would, then go to this section and you would make one motion.
Perfect. So we'll move on
That sounds
to,
good to me.
thank you so much. We'll move on to the justification piece.
You can take a note of the acceptance of the first piece and refer back to it later, just so that it doesn't get lost in the wash.
Sure, thank you so much.
You got it.
All right, folks, so looking at our justification here, we have a big block text quote. If you want to take a moment to review that. All right, everyone. So bringing us back to the last recommendation, we decided to take the links that were provided and turn it into language that was more in line with the rest of our recommendations thus far and justifications. What are your feelings on doing the same with this?
Madam Chair, is your question referring to the justification or the research links section?
Thank you for the clarification, Chelsea. Lisa Lee, for the record, the justification
Okay.
portion of this.
I think the justification looks pretty good. The only thing is the way this separating older and younger out looks weird. I mean, I'm not saying you shouldn't, but I think there should be a little bit, maybe specific efforts aimed at older children and younger children, because they're obviously going to be different, or you wouldn't have separated it out. But that's it. Other than that, it's fine. It looks okay to me. And I guess they're quoting someone from Samsung.
Any recommendations on language? I pulled up the data on percentage of children under age 1 removed to foster care due to parental substance use in Washoe County and statewide from 2012 to 2021. And also the percentage of children removed to foster care due to parental substance use in Washoe County by calendar year, again, from 2012 to 2021. Unfortunately, Washoe County has a significantly higher rate of removal for parental substance use than statewide. And that's for under the age 1 and all ages of children. So child welfare cases related back to parental substance use is a huge issue. For example, for infants, Washoe County's rate of removal for infants is 75.5% versus the statewide percentage of 25.4%. So it looks like, some places are impacted more than others. I'm not sure if we can capture kind of those trends in a short justification. And then to Dr. Dixon's point about the age group of children that are seeking, youth that are seeking services and unable to access treatment beds and often have to go out of state. I'm not even sure how to, I don't know enough about that issue at all to speak to a justification on that, but we definitely should include it.
What is, well, when you said those two percentages, the 75%, the 75% refers to what?
It's the percentage, 75.5%. It's the percentage of children under age 1 removed to foster care due to parental substance use.
In 75% of all live births to abusing women, or what?
No, of children that are removed and placed into foster care within our CPS system. So just out of all the infants within our child welfare system, 75.5% of them in the year 2021, the removal reason was related back to parental substance use for that group.
So does that mean that in the rest of the state, they're just removing a lot fewer children?
No, it just means that statewide, the percentage of infants removed due to parental substance use is a contributing factor to child maltreatment is 25.4% for 2021. I'm just looking at 2021. It has increased over time, but just looking at last year's number.
So, and where does Clark County fit in there?
I didn't ask for their data because I was just looking at Washoe County. I'm sorry, I don't have that data.
Madam Chair, Kelly Marshall for the record, if I could just provide context that this subcommittee heard a presentation, I believe it was on the SMART program from Child and Families Futures and START program, sorry, that was specifically talking about engaging parents in treatment for children who were at risk of child maltreatment or child welfare involvement. I think that was the spirit of the recommendation, was to facilitate entry into treatment for the parent and to reduce the separation of families.
That's correct, Kelly. Is there anyone on this subcommittee that has experience specifically with regard to access to treatment facilities and beds to divert youth at risk of higher level of care system involvement?
Madam Chair, Kelly Marshall for the record, I would just note the published Department of Justice report as a potential justification for the need, although they're trying to divert people from beds by ensuring they have access to early intervention. screening and early intervention, which I think is a little bit afield from the actual recommendation.
Thank you, Kelly.
What is your question again about beds? I'm not sure I quite follow what you were asking, Lisa.
Thank you, Dr. Dixon, Lisa Lee for the record. So the recommendation that we were looking at adopting with its added language from former Vice Chair Tolles was to include language regarding, well, let me just read the suggested alternative recommendation again. Significantly increase capacity, including access to treatment facilities and beds, that's the new language, for intensive care coordination to facilitate transitions and to divert youth at risk of higher level of care and or system involvement. So that piece, our current justification doesn't speak to that piece.
The need for increased beds, basically.
Correct. And I do think that recently published Department of Justice report on this very issue would be a great justification. I'm not really sure how to wordsmith that, so I'm happy to, let's hear your ideas.
Madam Chair, this is Steve Shell. I do know the state has a lot of data. We have a lot of kids that are being placed out of state. So I know that was a big focus in the DOJ investigation and report. I can't remember though from the specific language of the report if they specify how many kids are currently out of state, but I know they reference it in the report, or a general reference that there are kids being placed out of state. So maybe we could somehow incorporate that language into this.
Well, the other thing that's happening is, Dr. Dixon, is apparently I hear from the folks in Reno that there are not even any beds for younger children, you know, under say 12 or something, preteens, in that area. And so the only beds that even exist are here in Las Vegas. And most of our facilities don't have them either. So I think, and when I asked, so where are they sending them to Las Vegas? They don't know. So I can't figure it out. But you know, taking care of little children is not very popular in the psychiatric community because it requires a very high level of staffing. And so that's why they go out of state, where there's places that are set up more appropriately for kids with a lot of behavioral problems. And of course, behavioral problems frequently are either due to their drug use or their parents' drug use. So, but you know, I mean, this comes up all the time, wanting more beds. It's just not happening. And
Dr. Dixon, do you have suggested language around justification? I think between you and Steve.
well, I mean, the justification is correct. The action is the problem.
Well, I mean, recommendations for our justification bullet so that we can finalize. This is our last recommendation. So just a sentence.
This is
On-
Steve Shell. Could we simply just add a number 2 under justification that highlights the DOJ report? Just a simple statement, that sentence that references that the DOJ report was recently issued or issued on a certain date. Okay.
Yeah, and I think we should suggest language because I don't believe that our SEI team, they're sort of our administrative support from what I understand. So I think it's up to us, because this is a public meeting. We have to come up with the language here and vote on it. We can't table that and have the SEI kind of do that on their own. So I want to make sure that we're tailoring our language specifically here. And I can bring that up. Hold on, let me ask Google, because that I didn't read the report because I know myself and it would be too upsetting. So I was like, I can't do it. report, let me just look when that came out. I remember lots of people sending it out.
It was about 3 months ago.
Let's see.
I don't think it had a lot of really concrete suggestions. It was more findings of what than concrete suggestions. As I recall.
Madam Chair, Kelly Marshall, for the record, at the end of the report, there are like 7 remediation steps that are suggested. However, my understanding is that the state is currently negotiating with the Department of Justice on a remediation plan. So the state will have to do remediation and come to an agreement with the Department of Justice related to the report. If they don't, then the DOJ will sue the state, is my understanding.
Perfect. So I think we might have our language then. So it sounds like to me, we can reference as our justification, the investigation of Nevada's use of institutions to serve children with behavioral health disabilities issued by the United States Department of Justice Civil Rights Division on October 4th, 2022, provides recommendations for remediation, period. This committee suggests that the state of Nevada adopt these remediation strategies to enhance services for at-risk youth in Nevada or something like that. Help me out, y'all.
Madam Chair, I think I would say consider and adopt accordingly. That way, if we want to make any changes to the considerations.
Yep.
Okay,
Consider and adopt accordingly. Love it. Okay. And then that, Lisa Lee, for the record, that second recommendation, I'm trying to find my notes here. Hold on 1 second. That, well, I guess it's listed as number 1 there. It's that big lengthy quote from SAMHSA. I'm wondering if there's an opportunity to sort of synthesize that information into a really short sentence, and then include that link in our research links. And so, I guess to synthesize it, it would be parental substance use increases risk for child maltreatment and child welfare involvement, which increases intergenerational substance use. And then that's just the justification for why we need to have the interventions. Does that make sense? Unless anybody has another sentence.
no, this is Steve Shell. I think that sounds great.
All right, Kelly.
I don't have it. I mean,
I,
Laura,
so she had parental substance use increases risk for child welfare and involvement with child welfare, which increases intergenerational substance use. Is that right, Lisa?
Child maltreatment and child welfare involvement, which increases risk for intergenerational substance use.
Thank you.
What about the second one with the DOJ thing? Did we get that one?
Kelly Marshall, for the record. So if I understood it correctly, we were trying for an elegant solution, which is consider and adopt accordingly the recommendations for remediation from the investigation on the misuse ... from the Department of Justice.
Yep. Issued on October 4th, 2022, if that's relevant. Or just, hyperlink to the DOJ report. What do we think of those justifications? Feeling good about them?
This is Steve Shell. I think they're very appropriate.
Perfect. All right. Are we good to move on to our action steps? Okay. So I only see one funding action step here, which is to direct DPBH to grant opportunities for organizations to open or expand bed capacity and implement specialized child welfare programs that are not reimbursed by Medicaid or other payers.
Well, I'm still sure Steve could reflect on this too, but I don't know that there's the amount of money that it would cost is not really kind of the way you write grants. And we're talking huge sums of money to open or expand bed capacity, and it requires that generally the private sector invest the money, because the state is not doing this sort of thing anymore.
Dr. Dixon, Lisa Lee, for the record, do you think there's an opportunity to supplement funding necessary for organizations to do this kind of work with this opioid litigation funding?
Well, I think within the capacity we already have, say like there's one place in Las Vegas, I think, that does have some child and adolescent substance abuse programs. I suppose a grant could maybe help them expand bed capacity, but bed capacity is related to shortage of things like nursing, and I don't see how you're going to get a grant to solve that problem.
That's a great point, Dr. Dixon. Lisa Lee, for the record, I also wanted to point out that DPBH isn't the only one that could be asked. And so I'm wondering again if we need to broaden it to DHHS to include opportunities that might come through like Title IV funding through DCFS. I think expanding that language to DHHS to be more inclusive of all of those sort of sub-agencies would be helpful.
Madam Chair, Laura Hale for the record. I don't know if you all recall that Senator Severs Gansert mentioned at one of the SURG meetings about public-private partnerships for this very issue. And I'm not sure if that made it into other subcommittee recommendations, but just to, sort of broaden the purview, you could reference DHHS grants, but also to look toward public-private partnerships.
Thank you, Laura. And you know what, that is in our notes for this meeting, our attachments. It does have in bold, whether through public-private partnerships or the programs Dr. Woodard described. So thank you for routing us back to that, because I think if we didn't add this, that would be a missed opportunity. So I'm wondering if we could have a B action step, which is to, how do we make the verb, not explore, but pursue public-private partnerships to ensure increased capacity with, this is all linked, right? Because, like Dr. Dixon said, with the provider shortage, and you can't just manufacture new nurses, it really goes into some of the other recommendations about healthcare and behavioral health workforce and retaining and attracting attention retaining and attracting talent. And I think this could be kind of woven in that also. So pursuing, how would you add the language, you all? I think Steve and Dr. Dixon would probably be great at this one.
This is Steve Shelp. We could go back to the next slide. I was just, let's see. This is Steve Shell. I would say, direct DHHS to create grant opportunities and or pursue public-private partnerships to open or expand bed capacity. And I was going to add, Madam Chair, that's exactly what we're doing right now in the north between Renown and the state. We're actually opening adult services through a public-private partnership. So I totally agree with Ms. Hale on adding that here. I think that needs to be emphasized.
Perfect. That sounds wonderful. Thank you, Steve. And
So
on that,
Madam Chair, Kelly
I'm
Marshall,
sorry.
for the record. So what I understand is that it's changing DPBH to DHHS, direct DHHS to create grant opportunities and pursue public and private partnerships for organizations to open, etc. That's what you're doing with that action step.
Yes. And then, so on that note, I would recommend having a separate action step for the implementation of specialized child welfare programs.
So
So
just
maybe-
do a period after bed capacity and then just say implement specialized child welfare programs that are not reimbursed by Medicaid or other payers.
Yes.
Madam
And
Chair, this is,
Oh, I'm sorry. Go ahead, Steve. Sorry.
Sorry, this is Steve Shell. I was going to suggest also that we may want to leave in not reimbursed by Medicaid or other payers, but then emphasize the uninsured and underinsured, just so that we bring more attention to uninsured.
So Kelly Marshall, for the record, so Steve, was that for the direct DHHS part or the second part or both?
This is Steve Shell. I'm sorry, Kelly. That was for the second part.
Okay.
Yeah.
Lisa Lee, for the record. So typically child welfare services are funded not by Medicaid. I know that we do have clinical services that are covered by Medicaid, but our child welfare services are not. They're drawn down from a variety of sources of funding. So I personally think that the implementation of specialized child welfare programs should be a separate action step. It should be part B, and that it should just say that are not reimbursed by other payer sources rather than the Medicaid piece. Steve, does it make sense to add the Medicaid piece to the expanded bed capacity?
This is Steve Shell. Yes, I think I would keep that in the bed capacity. Yes.
So then where, Kelly Marshall, for the record, where does uninsured, underinsured go? In the first one or in the second one?
Lisa Lee, for the record, the second one, you don't have a choice whether or not to participate with child welfare when child welfare is involved in your life. It doesn't matter to us whether you have Medicaid or not, because we're not billing your Medicaid, right? So that doesn't make sense to have anything about insurance for the child welfare services, because they're, some of them are voluntary, but most of them are involuntary, if that makes sense. And we don't do the wallet biopsy to provide services for you. It's required.
So just to clarify, Kelly Marshall, for the record, so would action step B be implement specialized child welfare programs? Period.
That are not reimbursed by other payer sources.
By other payers.
Mhm.
Okay, other payer sources. Thank you.
Thank you. And then Lisa Lee, for the record, this is a question for Steve. Do you think, I'm not sure within SB, or I'm sorry, AB 374, but in SB 390, around the opioid litigation funding, there is a piece in there that the funds can be used for capital improvements. And that is a huge barrier for a lot of organizations who have the desire to expand, but really have difficulty coming up with that money for capital projects to do so. And so I'm wondering if this would be an opportunity to include language around that as well, since that's so often a barrier. The desire is there, the ability to build Medicaid is there, maybe the labor force is there, but what isn't there is this capital projects funding that can help organizations to be able to do these things. So I'm just wondering if there's an opportunity or if we wanted to be strategic around our language in that area here.
This is Steve Shell. I absolutely agree. That's actually part of the public-private partnership right now that I've been working on. So I think maybe we should specify capital improvements and or operational cost, because I think that's also a barrier for a lot of organizations. Some can't necessarily stand up the programs initially. It takes money to hire staff up front if you're not getting reimbursed yet. So I think maybe we should add that. I don't know how the others feel.
Kelly Marshall, for the record. So Steve, are you suggesting that as an addition to A or as a third, like as a C?
Kelly, this is Steve Shell. I think maybe as an addition to A. What do you think, Madam Chair?
Lisa Lee, for the record, I was thinking in my head that it was part of the recommendation for funding A.
So would it be to create grant opportunities and pursue public-private partnerships, including capital and operational costs to open or expand bed capacity?
Yeah, that's good.
This is Steve
Yes.
Shell. Yes, I agree.
That's a good place.
I just feel like that's such a big barrier to organizations that want to do it. And to Steve's point, the reimbursement model, it kills organizations. If you are a small organization and you cannot fund your operational costs and your staff costs, you're sunk by the time you get your reimbursement back from the state, and it's 90 days, 120 days later. You might not be able to pay your bills, for some of these organizations. So I think we have a lot of desire and willingness in our state. However, organizations are faced with countless barriers to actually doing the next right thing sometimes. So if we can make it easier for people to do the right thing because they want to, I think that'd be great if we can be part of that solution.
And this is Steve Shell. This will also give the state some latitude in being able to issue funds for capital improvements. A lot of the grants they've issued in the past have not included capital or even the operational costs for that matter, or a lot of the operational cost. So I think this is good.
Kelly Marshall, for the record. So based on what you just said, Steve, it sounds to me like to create grant opportunities, including capital and operational fund opportunities, and pursue public-private partnerships is how it has to be written, because you're specifically referencing the grant opportunities, not the public-private partnerships.
This is Steve Shell. That's correct, Kelly. That's how I would word it. Yes.
Okay.
Lisa Lee for the record. What's the verdict? Kelly, did we do it?
Yeah, I think, so Kelly Marshall for the record. So we have a revised justification. We have action steps A and B, which are now separated out. We just finished wordsmithing A. And then we're taking the link from SAMHSA for the, under the justification, moving it to the research links. And then we have the revised recommendation as already considered per DAG Becker.
I heard my name again.
Just that we're not revisiting the recommendation, Kelly Marshall for the record, because it's already been considered. So now they're moving towards the motion for the entire package.
Yep, just like we talked about. All right.
Yes, sir. So I think at this time we can entertain a motion.
This is Steve Shell. I will make a motion to approve recommendation number 6 with the changes to the justification and the 2 action steps that have been noted by Kelly Marshall.
This is Chelsea Cheatham for the record. I second that motion.
Great. And just to clarify before we take it to a vote, that is inclusive. I just want to clarify the recommendation 6 had some proposed changes to it. Is that incorporated in your motion?
Madam Chair, this is Steve Shell. Yes, it is.
Okay, perfect. We have a motion and a second. All those in favor, please signify by stating aye.
Aye.
Aye. Any opposed? Any abstentions? We did it unanimously each and every time. Good job, everyone. All right, awesome sauce. We are moving to our second period of public comment. So again, just a reminder to anyone who still remained with us, public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised until the item and under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 Nevada Revised Statutes 241.010. And so if you'd like to speak in public comment, please unmute yourself and state your name for the record.
Kelly Marshall for the record. Madam Chair, I don't see anyone unmuted or any hands raised. And no one has joined solely by phone.
Okay, perfect. Well, we'll go on to adjournment. So I'd like to thank everyone for showing up today and happy holidays to all of you. Take good care of yourselves.
Thank you all.
And we'll
Bye,
see you all
everyone.
in a week.
See you in a week.
All right, it was a pleasure, guys. See you later.
See
Thank
you.
you, Dan.
Bye-bye. Thank you.
All right.